introduce our lecturer and presenter this evening, one of the educators and clinicians that are known around the world, Dr. Jennifer Harthen. Dr. Harthen is chief of the Cornea Center for Clinical Excellence and is an associate professor at the Illinois College of Optometry. Now, I'd just like to sort of tee up the conversation for this evening. We're going to be talking about managing the post-surgical irregular cornea patient with a unique silicone-hydrogel soft lens. Now, one of the challenges, or two actually of the challenges that we can see clinically in our practices are the post-surgical patient, but those that drop into a couple of different buckets. One is the post-refractive surgery patient who went into refractive surgery hoping that the outcome would be that they wouldn't have to wear correction after their procedure, and then now are sometimes told after regression or just a different than expected outcome that they may need contact lenses. So these patients are sometimes sort of two strikes on them psychologically as they go into this process, and they certainly have difficulty if that option is gas permeable lenses, so they much prefer a soft lens option. And this was the subset of patients that this RevitalEyes post-surgical lens was initially developed for. And Dr. Harthen will explain the design features that make that the case. But the second subset of patients that we're going to talk about tonight are those that are surgically altered corneas as a result of penetrating keratoplasty. And that is a different subset of patients. Traditionally and in the past, we were sometimes forced for acuity reasons to try to fit these patients with a GP design, and we did that because we needed the visual acuity and the oxygen permeability. But now we've got a silicone hydrogel option for these patients that Dr. Harthen's had a lot of experience with. So now, having introduced Dr. Harthen and sort of set up the topic, I'd like to turn it over to Dr. Harthen for the presentation. Go right ahead, Doc.
Thanks so much for the introduction, Tim. As we go throughout the presentation, if you have any questions, please feel free to ask those, and we will try our best to answer all of your questions. If for some reason we are not able to answer all of your questions during the presentation, we will do our best to email you after the presentation with the answers to your questions. So I do want to mention that I am involved in some research, speaking, and consulting for several different companies, but I have no financial interest in this specific lens design. Our goal for this evening is to introduce you to the RevitalEyes post-surgical lens made out of the definitive silicone-hydrogel material. We will review the fitting set and the unique fitting characteristics of this design. We will approach how to fit certain patients so that you have a successful outcome. And then at the end, we'll review both post-surgical and irregular clinical cases. The RevitalEyes post-surgical lens is a custom manufactured soft lens specifically designed to fit the surgically altered cornea when vision is less than optimal. And I will admit that when I first started fitting these patients, I was a little bit skeptical about using a soft lens to correct these patients, as most of the patients who presented to our clinic we would often try to correct with gas perm lenses or corneoscleral lenses. I also was a little bit skeptical about how difficult could this really be. As it is a soft lens, I didn't think that we needed to follow the fitting guide, but I will tell you that it is imperative to follow the fitting guide and use the consultants that are available at Metro to have a successful outcome, because although this is a soft lens, there are some unique characteristics, and you want to follow the fitting guide as much as possible to have a successful outcome for your patient. RevitalEyes received FDA clearance in June of 2008 for post-refractive surgical cases, and then it also received approval later on for PKP corneas. It is fit using a simple diagnostic system and is custom made to the individual eye. It can be custom manufactured to the patient's prescription, and it's available in a wide range of spherical and toric parameters. It can be made out of either a hydrogel, hydroxysilicone B, 49% water content material, or out of a silicone-hydrogel material, Afrofilcon A or the definitive. The great thing about the definitive material is that it allows more oxygen, especially for those post-surgical corneas who need more oxygen. And it also has a high water content, so it has an inherently wettable surface. These patients often report that when they're fit in this lens, their eyes are much more comfortable. They have less dryness than they did previously with other lens designs. Post-refractive corneas typically exhibit this topographical profile in our ideal cases for this lens, as this lens features a base curve that is flatter centrally than peripherally. Here you can see in this topography that we have a flat central cornea and a steeper peripheral cornea. Post-PK patients who have oblate corneas are also great candidates for this lens. Here you can see a 3D map of the same presentation where we have a flatter cornea centrally and a steeper cornea peripherally. The diagnostic kit incorporates a simple 5-step fitting process that we will go over in just a few minutes. Before we go over the actual fitting process, I'd like to go over the unique features of this lens. This lens, as I mentioned before, is reverse geometry. So the central portion of the lens is flatter than the fitting curve. So that base curve is what's going to give the patient great vision as it matches that central cornea. The peripheral fitting curve reflects the unaltered portion of the cornea, and this is what gives us that reverse geometry. Here again you can see the different curves. We have our central base curve that is flatter than our peripheral curve, and it is also flatter than our fitting curve. The nice thing about this lens is that the peripheral curves can be altered independently of the base curve. So if we are not getting enough movement, or if we have too much movement, we can make the peripheral curve flatter or steeper than the base curve. And here is our 5-step fitting process. The diagnostic fitting set, all of the lenses are plano in power, and their base curves range from 7.8 to 9.0. For our post-refractive surgical cases, we're going to start with about an 8.4. For our post-graft patients, we're going to start with an 8.1 or steeper lens, as these corneas generally are steeper than our post-refractive surgery patients. After we apply the lens, we're going to note rotation if we see any. Not only will we note the direction of the rotation, but how stable the rotation is. When we apply this lens, we want to see movement of at least 1 millimeter. And when we order the lens, we're going to order the base curve, the rotation notation, and any over-refraction. The great thing about this lens as well is that when you order your patient's lenses, you're also going to discard your diagnostic lenses that you use from your fitting set. And the company will send you both the patient's lenses and complementary replacements to refill your diagnostic fitting set. So after we've taken our topographic analysis, we're going to select our initial base curve. And again, for our post-LASIK, our post-PRK patients, generally you're going to want to start with an 8.4 lens. For our post-PK patients or corneal graft patients, we're typically going to start with an 8.1 or steeper lens. After applying the lens, we're going to allow the lens to settle for several minutes, and then the first thing we're going to do before we take an over-refraction is we're going to look at the movement. If we determine that the movement is optimal, where we have about 1 millimeter or less, we're going to then proceed to over-refracting the patient. If we don't have enough movement, we're going to apply the next flatter curve in the fitting set and reevaluate. If we determine that there is excessive movement, we're going to apply the next steeper curve lens in the fitting set and reevaluate. Once we determine the appropriate movement, then we will begin our over-refraction. And we all know that these patients can be very challenging to over-refract. If you're having a difficult time over-refracting the patient, you can also use an autorefractor. You can also do topography over to give you a good idea of how much cylinder you have to place in the lens. Some of these patients we're going to be able to just do a sphere-only over-refraction, and some of these patients we're going to have to do a sphere-sill. One thing that's also helpful with these patients, if you can trial frame and have the patient select their own axis, as some of these patients, again, can be very picky about their vision. Post-refractive surgery patients can be very, very challenging to fit with a lens. Most of them have spent a lot of money to get good corrective vision, and now you tell them that they have to wear contact lenses after their surgery. Some of these patients are not going to be willing to wear a gas perm lens or a lens that they might think may be uncomfortable. So this is a great option for those patients, and that's not only going to give them great vision, but it's also going to be a very comfortable option for them. For our post-refractive surgery patients, you're going to order the prescriptive lens according to your over-refraction, and you can order this in either the hydrogel material or in the definitive. However, with your corneal graft patients, you definitely want to order these lenses in the definitive SiHy material, as these patients are going to require more oxygen. Most of my patients that I order these lenses for, I always order them in the definitive, just because it does allow more oxygen through the lens, but also it's very comfortable material for these patients. These lenses are replaced quarterly. What we usually do is order one lens first, make sure that we have the appropriate prescription, fit, comfort level, and then you can order the remaining year supply. It is recommended to use a peroxide-based solution to clean these lenses. Some patients will also need a daily cleaner, and any of the multi-purpose solutions that are approved for silicone-hydrogel materials will work well for these patients. Some patients, if they tend to coat their lenses, have problems with meibomian gland dysfunction, may also need an enzyme cleaner. And for these patients, an enzyme cleaner used once a week will be sufficient. Now, sometimes the first lens, as we know, or even the second lens, may not be ideal. The one thing that's very important with this lens is not only to try to achieve as good a vision as we possibly can, but also ask the patient what their vision is doing through the lens. If the over-refraction is unstable and we're not achieving the vision that we think we should, it probably indicates that the base curve is not correct. If the patient's vision improves after they blink, then that typically means that the central fit is too steep. So then we will want to apply the next flatter base curve. If the patient's vision declines after the blink, then that indicates that the central fit is too flat, and then we'll want to try the next steeper base curve. For some of these patients, if you believe that your central base curve is ideal, you could also increase the center thickness on the lens to help stabilize the vision. But I will tell you that in more instances than not, if your vision is not what you expected, the base curve is off. Really, I don't have to order many of my lenses with an increased center thickness to stabilize the vision. I usually just have to alter the base curve. If the central fit is ideal, and we have now achieved an over-refraction that is stable, but maybe when we look at the periphery, we might notice that maybe the lens is either moving too much or the lens might be fluting. What we want to do is we want to note the best central fitting base curve and use the next steeper lens to determine the best peripheral fit. For example, if we were to apply the 8-4 base curve, but maybe we saw a little bit of fluting in the periphery, then the next steeper lens would be the 8-1. If we had a better fit peripherally, we would order the lens as an 8-4 base curve with our over-refraction, notate the rotation, and then order the periphery as an 8-1. If the peripheral fit is too steep, where we have good vision but maybe the lens isn't moving quite enough, we would note the best central fitting base curve and then use the next flatter lens to determine the best peripheral fit. So again, for example, if we go back to that 8-4 base curve lens, we have great vision. We're going to notate the base curve, our over-refraction, any rotation, and then we would apply the 8-7 base curve. If we have better movement, then we will order the lens with an 8-7 peripheral curve. With this lens, we have 3 rotation indicator marks that are vertical lines inscribed onto the anterior surface. The center line is at the 6 o'clock position, and then we also have one line 10 degrees to each side of the center. When you're evaluating the rotation, you want to look at that center line, and this is what we should observe in primary position. Here we can see that the lens is rotated to the right, and remember that you want to observe the rotation from your perspective. And here we see that we have rotation to the left. Now this lens may not be an option for every single patient. I've had many patients where this lens did not work, but the great thing about being contact lens fitters is that we have multiple options in our toolbox to fit these patients. The other thing I will say is that if this lens does not work for one of your patients, don't be discouraged. Keep working with it, because it does take some experience fitting the lens to know what works and what doesn't work for some of these patients. The other thing I would recommend is if you are having problems with some of your troubleshooting, call the lab, talk to consultation, because they are fantastic at troubleshooting and give you an idea where to go to next.
Dr. Harthen, this is Tim. I just thought this might be a great time to pause and allow our attendees to type a question into the question box, and we could take a moment to answer them. One of the questions we have already is all this fitting information available in the fitting guide? Well, certainly the answer to that is yes. There will be a fitting guide that will come along with the diagnostic set that you will automatically receive due to your attendance at this broadcast. But I will also say that this webinar is being recorded and will be posted on Metro Optics' website for future reference. So are there any other questions that we have about the fitting? I think Dr. Harthen said it, but it's worth mentioning again that the base curve and the peripheral curves can be done independently in the finished design. In other words, if you have a base curve that you like, but you require the periphery of another of the diagnostic lenses, all you have to do is order the lens that way, notating the base curve, the peripheral curve, the rotation, and your over-refraction, and that's all you'll need to get the patient started. I don't see any other questions at this point, so let's take a look at some of the clinical cases that you have, Dr. Harthen.
Thanks, Tim. I think, sometimes when we hear about fitting these lenses, it can be a little bit challenging to remember all the kind of ins and outs, but one of the ways that I learn the best is through clinical cases. So what I put together for you is several cases, both refractive surgery, certain types of surgical procedures, PKs, that show you how this lens can work. I really, really like this lens because it's very comfortable. It works for these patients. And hopefully that you will feel more comfortable in fitting your patients after the end of reviewing some of these cases. So our first patient is a 41-year-old African-American female who has keratoconus. She also had intacs in her right eye in 2005. And for those of you who have had intacs patients in your office, these can be one of the most challenging patients to fit. Not only are their corneas very difficult to fit, but also what we worry about is neovascularization around the area of the intacs. When we do see areas of neovascularization, one of our main concerns is to make sure that this does not become worse. This patient presented complaining of both blur at distance and near, and she also reported that she had significant dryness with her current contact lenses. This patient came in wearing an unknown brand of soft contact lenses, and the power of her contact lenses, as you can see, she had 4 diopters of astigmatism in her right eye and 7 diopters of astigmatism in her left eye. With her right eye, she was able to see 20/25ths, and with her left eye, 20/70ths. These lenses she had had for over a year, and she did report that she did have some distortion, especially in that left eye, as well as some dryness. When you looked at her contact lenses, you could also see that she did have some coating, and she was wearing them basically all waking hours of the day. Whenever you see these patients, some of them will come in with referrals, some of them will come in with known contact lenses. I would recommend to take your own entering data. Do your own manifest refraction as best as you can and take a good topography, as that can help you fit these patients later on. So with a new manifest prescription, we were able to get the patient to 20/30ths, which is glasses alone in her right eye, and 20/70ths in the left eye, and she did have a small add. But again, you can see that she did have quite a bit of astigmatism in that left eye, and that eye she was getting more distortion. Some of our additional concerns with this patient is that she did have some inferior neovascularization of that right eye where she had the intact inserted. We also had some dryness concerns as she did wear her lenses all day long. After discussing multiple options with this patient, she reported that she did not want to wear gas perms. She had worn them before she had had her intakes and reported that she had significant comfort and dryness issues with those. And ultimately, this patient needs more oxygen than what she's getting through her current soft lenses. Now, if we look at the topography of her left eye, we see that she has more inferior steepening, and she has more of a pellucid. In her right eye, we can see that she has some flattening in the center. You can see the steepening in the periphery where she had the intakes, and she also has a central hot spot. Now, we decided to fit her with the RevitalEyes lenses because she was already wearing soft lenses, but also we know that with this lens it does give us that reverse geometry, so we were hoping to get better vision, but also with the fact that we could get this lens in the definitive silicone-hydrogel material, we are able to get more oxygen through to her corneas. So with the right eye, we selected an 8-1 base curve, and we were able to get her vision to 20/20. And with the left eye, we fit her with the 8-4 base curve. We're also able to get her to 20/20. And we take a closer look at her corneas, we can see that area of inferior neovascularization. We are happy to report that she has been stable for over a year, and her corneal neovascularization is stable. When we dispensed her lenses, she cried. She was overwhelmed with improvement not only in her vision, but also in her comfort. The patient is now able to wear the contact lenses comfortably for up to 16 hours a day. She isn't having to use any rewetting drops. And again, the big thing is that we're not seeing an increase in that neovascularization. Our second patient is a 48-year-old Hispanic female who had underwent LASIK in 1999. Since then, she's developed post-LASIK ectasia. With her current contact lenses and with glasses alone, she reported significant blur and image distortion. She had tried gas perm lenses prior and was unable to adapt because of the discomfort. She did like the vision with the gas perms, but just couldn't get used to how they felt on her eyes. The one thing is with everything that this patient had gone through, both her surgery and now the development of the post-LASIK ectasia, being unable to adapt to contact lenses, she did have pretty significant depression and anxiety. She had also had some personal issues that she was just really kind of hesitant about trying some new lenses. She was wearing some unknown soft contact lenses, and as you can see, her vision is pretty horrible. 2200 in the right eye, 21/50 in the left eye. We were able to improve her vision to 20/50 and 20/40 with a manifest refraction. And one thing that's important to note with these patients, if you're unable to correct their vision with a manifest refraction better than about 20/100, this lens may not be the best option for them. If they have significant central corneal scarring, this lens may also not be a great option for them. Now when we look at her corneas, we can see that she doesn't have that typical oblate corneal appearance on topography. But she does have some central steepening in the left eye and also in the right eye. So the initial lens that we applied to her right eye, because her corneas were a little bit steeper based on topography, was the 8-1 lens. And when we look at the lens, what we're looking for is full corneal coverage, pretty much equal centration. We want to make sure that we don't see any bubbles in the periphery or at the limbus. We also want to look at the periphery and make sure that we don't see any fluting of the edge. The lens rotation we also want to look at and make sure that we see less than 10 degrees. For the left eye, we selected the 8-4 lens. And again, when you're observing these lenses, you want to have the patient look straight ahead and an up gaze. It's also important to have the patient look in all different directions, superior, inferior, nasal, and temporal, to make sure that the lens is centered. When the patient looked up with her left eye, we can see that the lens is rotated 10 degrees clockwise. What's even more important is not only that the lens is rotated 10 degrees or more, but the rotation was not stable with the blink. So with the right lens, we had 1 millimeter of movement in both straight ahead gaze and an upward gaze. She only had 5 degrees of rotation clockwise, but the rotation was not stable with the blink. In the left eye, the movement was 1 millimeter and straight ahead and an upward gaze. She did have 10 degrees of rotation clockwise, and again the rotation was not stable with the blink. Even if all other fitting characteristics are optimal, with 10 degrees or more of rotation, when the power is added, it will likely result in the lens rotating to another position when the full power is added. So because of this patient's rotation being unstable, and with that left one rotating 10 degrees, we ordered each lens with the same base curve, the 8-1 in the right eye, the 8-4 in the left eye, but we ordered it with 1 step steeper in the peripheral curve. So our peripheral curve that we ordered for the right eye was a 7-8, and for the left eye was an 8-1. And here we can see the patient's lenses. Here we can see the lens in the right eye and in the left eye. And as the patient is blinking, we see that we have less than 1 millimeter of movement. The patient is looking to her left, to her right. We see that the cornea is fully covered. The lens is nice and centered, and we have less than 10 degrees rotation. Upon dispense of the lenses and her follow-up, the patient reported that she is significantly happier. She's spending more time with her family, her new granddaughter, she's traveling more, she's able to wear the lenses comfortably during all waking hours, and was able to get her life back. Our third patient is a 48-year-old African-American male who is keratoconus in both eyes. Now this patient was very challenging. When he first came in, I didn't initially think to grab this lens. The reason was because he had 3 corneal transplants in his right eye and 2 corneal transplants in his left eye. With his current contact lenses, he reported significant dryness, irritation, redness at the end of the day, and he did have some blur at both distance and near. He also reported with his current contact lenses that he had fogging during the middle of the day. So this patient was wearing scleral lenses when he presented, and you can see that his vision is quite good through these lenses. He's 20/20 minus. But he was frustrated with handling the lenses. He was frustrated with how to put them on, how to take them off, that he would have to fill the lenses prior to insertion. He didn't like the care method for them. He also did not like the fact that he would have to remove them halfway throughout the day to clean them, rub them, refill them, and reinsert them. And overall, they just weren't as comfortable for him as he had wanted. With the new manifest refraction, with 4 diopters of sil in the right eye, we were able to get him to 20/30ths, and in the left eye, he had 7 diopters of sil and was 20/70ths, and he had a low add as well. What was most concerning about this patient, and what was concerning in trying to refit him, is that he had very thick scarring at the graft-host interface. He also had a history of recurrent iritis in both eyes. Also, with all the incisions that he had, he had inferior neovascularization, and he also tended to have heavy surface coating with his current contact lenses. So after a lot of discussion, we talked to him about possibly trying a new lens design. When we look at his topographies, you can see how irregular they are, but you can also see that he is flatter centrally and steeper peripherally. Because of this pattern, we decided that maybe he would be a good candidate for the RevitalEyes lens. When you look at his anterior segment, you can see that he has very thick scarring at the graft-host interface, more so the left eye than the right eye. But you can also see that he does have some inferior neovascularization, which is also concerning, so we know that we need to give this patient as much oxygen as possible. When you look at his eye close up, you can also see how injected he was. And this is how his eyes looked every time he came in, whether or not he was wearing his contact lenses or not. His eyes just didn't look happy. So what we decided to do is try the lens. We told him that we had another option. His vision may not be quite as good because we really weren't sure how good we were able to get his vision. but that we would try it and see if we could get him something more comfortable, something that he didn't have to remove during the middle of the day, and something that maybe didn't coat quite as frequently as his previous lenses. So because his corneas were steeper, we started with an 8-1 base curve on the right eye and the 7-8 base curve on the left eye. And we were thrilled at what we were able to achieve improve his vision to 20/25 plus in the right eye and 20/20 minus. Now, one thing that you can see in that right eye is that we have a bubble right over that area of his scar. The left eye, when we were observing the lens, it wasn't moving quite as much. So because of the bubble and the movement that we were not having, we decided to reorder the lenses with the same base curve because he was able to achieve such great vision, but to flatten the peripheral curve on each eye. And we also ordered a double reverse. We steepened that reverse curve or the fitting curve to eliminate the bubble. Some of these patients are going to be a lot steeper where we have that graft-host interface, so you may need to steepen that reverse curve to vault over that area. So with the right eye, we had initially ordered an 8-1 base curve. So with the periphery, we ordered an 8-4 peripheral curve. With that left eye, we had a 7-8 base curve, so we ordered it with an 8-1 peripheral curve. He was thrilled. He's one of our favorite patients. He's able to wear his contact lenses all day long. He has significantly less coating. He reports that he doesn't have fogging throughout the day. He loves the handling. He loves the feel. When he comes into the office, he's given everybody a hug. He high-fives the staff. He talks to the students. He's thrilled about what these lenses have done for him.
Dr. Harthen, this is Tim, gently stopping you for just a moment to ask a question or two that we've been asked by our attendees. Just one very quickly, could you review the contact lens disinfection and care regimen that you prefer?
Absolutely.
For these patients?
For these patients, you definitely want to use a peroxide-based system as their nightly cleaner. This is really going to keep the lenses clean and disinfect them. However, some of these patients will also need a rub every single day. So before they put the lenses in the peroxide solution, you can suggest that they use a multi-purpose soft solution and rub for 30 seconds. And any of the multi-purpose solutions that are approved with silicone-hydrogel lenses can be used with the definitive material. For patients who tend to coat their lenses or need an extra cleaning, you can recommend an enzyme cleaner for them to use once a week or once every 2 weeks.
Great.
But some patients are going to be just fine with just the peroxide solution alone.
Terrific. Actually, we've got another question that refers back a few patients back, so I hope you can orient us around patient number 1. And
absolutely.
The question was, or is, what keratometric value led you to select the 8.1 base curve and not another diagnostic curve first?
Absolutely. So for patient 1 was our intax patient. And the reason why we selected the 8-1 base curve is because this patient's cornea almost looked like a post-graft, where we had some steeper case centrally. If you remember from the topography, the patient also had an area of steepening in the center, then it became flatter, and then it became steeper again. Based on our experience, we decided to go with an 8-1 just as a starting point, and it ended up working. For patients where you notice that their topographies, their K readings are a little bit steeper, you want to start with at least an 8-1, and sometimes you'll have to go to the 7-8. For patients who are more post-refractive surgery, you start with the 8-4 and can go flatter from there. But for your cones, your post-LASIK ectasias, your post-grafts, most of the time you're going to start with the 8-1. And not in every case is that going to be the same way, but for most cases it'll be the 8-1 to start with.
Great. Well, thank you. That, I think, is a great answer. And barring any other questions, I don't see any at this point. Let's go ahead with patient 4.
Okay. So this patient was fun. He came in and he knew in his mind what he wanted. He was a 56-year-old male physician, and he had had a corneal transplant in his right eye 18 years ago after he had an infection from a previous trauma. He had tried gas perm lenses, hybrid lenses, and had discontinued secondary to discomfort, pain, redness, especially with his hours that he was working in the hospital. He really just didn't want to bother with contact lenses. However, he did complain that with his glasses, he had significant image distortion. Now, when he came to our clinic, he was referred to us for a contact lens fitting, and he told us, I'm a hard patient. You're not going to be able to find a contact lens that's going to work for me. I've tried everything. You might be good at what you do. You might enjoy what you do, but I guarantee it, you're not going to find a lens that's going to fit. I just want new glasses to see if I can help decrease some of this image distortion. So we had a long discussion, and we had tried to talk him into trying a new contact lens, and he's like, no, 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 no. I told you you're not going to be able to fit me with anything that I'm going to be happy with. Just release my glasses prescription. So that's what we did. We tried to achieve the best glasses prescription we could. And with his right eye, you see that he's plus 50, minus 4 1/4. And the best we could get his vision in that eye is to 20/50ths. In the left eye, he's minus 1, minus 75, and 20/20. So he has almost 3.5 diopters of an ISO between the two eyes, so you can see why he might be having some difficulties with just glasses alone. So we dispensed the glasses, and after 2 weeks of wearing his new glasses during work, he presented, he returned, and he said, I'm still having a problem with my image distortion. I guess I'm going to allow you to try a new contact lens. So we talked about many, many different options, and we decided that the RevitalEyes might be the best option for him as far as comfort, vision, problems with the dryness and the redness. In his right eye, he had a lot of distortion. His K readings were a little bit on the higher side, and he was really, really distorted as far as the topographic analysis. We were able to get his vision to 20/25 with the 8:1 base curve. We did have more sil in that lens. We also made this lens a little bit larger in diameter just to make sure that we had full corneal coverage and the centration was great. He came back and he apologized after he had his lenses dispensed. He reported that his vision was stable. He was able to wear the lens all day when he was at the hospital. He was very comfortable, did not have any dryness, had less irritation, and then he did wear spectacles over his contact lenses for that mild correction in his left eye and also to give him that add up close. So he's been a great source of referrals as he's now referring patients in to see us because he has been pleased with the lens. And again, some of these patients have been through a lot. So sometimes when you try to suggest, let's try something different, they may be a little bit hesitant. So it's important to have a really good conversation with your patient about what are their expectations, what are they trying to achieve, but it's also really important to control your patient's expectations. Again, we've shown a lot of cases here where this lens has been successful, but sometimes, as we know, different lens designs don't work for every single patient. So if something doesn't work, we try something that might work for them. And again, don't be discouraged. Keep trying different lenses because you will find something that works for each patient. This next patient is a 67-year-old female who underwent corneal transplant in her left eye in 2011 following complications from cataract surgery. She presented never having worn contact lenses previously and did notice that she did have distortion with glasses alone. She was a little bit hesitant to try contact lenses, but her son had actually heard about the clinic and suggested that she try it to help reduce some of that image distortion. Now her vision uncorrected in that right eye is fantastic, 20/30, and in her left eye is 21/50. With the manifest refraction, we're showing -50, -150 in the right eye, which doesn't improve her any better. She's still only 20/30. It was surprising that left eye we weren't able to have her accept any astigmatism. She was just taking a sphere-only prescription and had 20/70 acuity, and she did have a moderate add. Now her cornea is very, very irregular. We do have some areas of flattening and some steepening. And her corneas were surprisingly, even though she was a post-PK, her K readings were a little bit flatter. Now typically with a post-graft patient we normally start with an 8-1, but because her corneas are flatter, we decided to go with a flatter base curve. The other thing that that patient complained of is that she had a lot of light sensitivity, and you can see that her pupil is very irregular. So with her right eye, we fit her in the 9-0 base curve, and with the left eye we fit her in the 8-7 base curve, and we were able to improve her vision to 20/20ths and 20/25ths. Not only were we able to achieve 5 lines of improvement in her visual acuity, as soon as we put on those lenses, she noticed an immediate reduction in her image distortion and in her light sensitivity. She wears the contact lenses comfortably all waking hours. She's now come back to get her second annual supply. Her son that recommended that she try contact lenses had also never worn contact lenses, so now he's become a patient as well and is wearing contact lenses comfortably. Our last patient is a 49-year-old African-American female who had a traumatic cataract in 2007, had cataract extraction. After the cataract extraction, developed bullous keratopathy. For all her corneal issues, she had a DSEC in 2011, and her medical history is unremarkable. Her uncorrected vision was fantastic, considering everything that she had gone through. In the right eye 20/50ths, in the left eye 20/20ths. With a manifest refraction alone, we were able to improve her vision to 20/25ths in the right eye. When we look at her topographies, you can see the irregularity, but you can also see the area of central flattening and a steepening in the periphery. One thing with this patient is she also had a lot of dryness and a lot of staining, and you can see the staining reflected on these images. With this patient, to monitor her corneal changes, we also did an anterior segment OCT. And you can see how much more stable her cornea has after the bullous keratopathy, after the DSEC. And you can also see her clear posterior chamber IOL. Now with her lens, typically again, with some of these patients, you usually think, well, maybe I'll start with an 8-4. But because her K readings were steeper, initially we started with an 8-1. And we noticed that that lens was moving too much. So then we went to the 7-8. With the 7-8, her vision was stable. She only required a sphere-only over-refraction. Her vision was able to get to 20/20ths. With the lens, she's able to wear it comfortably all day long, and she's also noticed an improvement in her dryness. When she's worn the lens, after wearing it for several weeks, we also noticed an improvement in her staining of the cornea, and she now reports that she only has to use her preservative-free artificial tears twice a day versus many times throughout the day. So with these lenses, you can see that with the definitive material allowing more oxygen through the lens to the cornea, it's a game changer. We're allowing these lenses to be more breathable and safer for incisional procedures. We've seen several cases where this lens has been successful for graft patients, intact patients, and we haven't seen any worsening of their neovascularization after a year to 2 of wear. This lens is a great option for patients, and it's a great option as an alternative to GP lenses. It's very easy to fit, it offers great comfort, and it improves vision. Again, if you're not noticing the improvement in vision that you expect, the base curve that you selected is probably off. Ask the patient what their vision is doing. Is it improving after the blink, or is it worsening after the blink? And based on those guidelines, you modify your base curve and you can get better vision. This is a great initial lens for patients who have had post-surgery, who have oblate corneas and mild to moderate astigmatism. It may not be the best option for patients whose vision is worse than 20/100ths or have central corneal scarring, but this is also a great option for any patient with an oblate cornea who has failed with GPs, either corneal lenses, corneoscleral lenses, or scleral lenses. This lens is a great option for any surgically altered cornea, and again, in that it offers good vision, good comfort, and is a very healthy option. I want to thank you for your attention, and if you have any further questions, please let us know.
Dr. Harthen, I did get one question that I'm going to ask. I'm not certain that I completely understand the question, so I'll just ask and see how you respond. One of the questions says, when taking patients out of sclerals and putting them into RevitalEyes, do you think these patients may lose the corneal stabilization that sclerals and GPs offer? And I don't know whether they're talking about the stabilization of the visual acuity with gas perms, or the actual stabilization of their
the cornea
corneal
itself.
Topography. Yeah.
I don't think, as far as the topography is concerned, that we lose any stabilization. For some patients, you might notice a couple letters or a line worse of vision than with a GP lens or with a corneal scleral or scleral lens. Some patients, you're not going to notice this. And I think, again, it's really about controlling the patient's expectations. You know, why are we having to remove the patient from their current lenses? That would be the one question I would think about. Is it because that they just can't handle the lens, that they're really having difficulties? Or maybe that initial lens, it needs to be modified in its fit. Maybe it's not fitting appropriately. But again, you know, you kind of have to weigh the pros and cons with each case that comes in your chair, treat it uniquely, because every case that you see, for example, if you see a post-graft patient and then the next patient you see is another post-graft, you may fit them differently based on what you're observing and based on what the topography is showing you.
That's great. I think in the last number of years, the acknowledgement that there are irregular corneas in post-surgical patients that can be fit with some version of a soft lens, like RevitalEyes, is been a real revelation and been a real boon to clinicians who have these patients coming in out of their clinic every day. That's it for the questions, and I did want to talk to the slide that you see in front of you. Whichever email address that you signed up for the webinar with is the one that Metro will be contacting you to set up details for the shipment of your complimentary RevitalEyes fitting kit and for the setting up of a corresponding account. And so if you have any questions related to the clinical portion or the training portion of this seminar, that is Dr. Harthen's email address that you see on the screen. And I know that she would be delighted to field your email questions, answer them as best as she can. And I want to also thank you for attending this webinar this evening. It's been great. I want to thank Dr. Harthen for her knowledge and her ability to teach us on these unique and special designs for unique and special patients. And so, barring any other questions, I think we should say thank you and good night.